Our final speaker today is Dr. Crochet Charles, and she's our pharmacy clinical practice specialist. Dr. Charles began her career in pharmacy as a pharmacy technician in St. Luke's Episcopal Hospital in Houston, Texas. After earning a doctorate pharmacy degree, she did a one-year pharmacy practice residency at St. Clair Medical Center in Moorhead, Kentucky. She came to UTMB in 2001 as a staff pharmacist and as I had said, as the clinical pharmacy specialist in the Division of Geriatrics at UTMB. She's a certified geriatric pharmacist and has presented several lectures focusing on safe use of medications among geriatric patients.
Today's lecture will be on pharmacology in elderly patients. The objectives are listed. We're going to go over the demographics of pharmacology for elderly patients, identify age-related pharmacokinetic changes, describe pharmacy-related risk factors for the geriatric patient, define polypharmacy and identify risk factors, evaluate adverse drug reactions as it relates to elderly, and evaluate the appropriateness of drug therapy. Elderly patients 65 and older make up about 13% of the population, yet they consume about 33% of all the prescription medications. That doesn't include your herbals, your vitamins, your over-the-counter things. That's all prescription medications. By the year 2040, those numbers are expected to increase by 25 and 50% respectively. And the average elderly patient consumes about 5 to 12 drugs daily, and less than 5% of elderly patients use no drugs at all. Here's a little quote I found. Inappropriate medication use is a major patient safety concern, as we know, and especially for the elderly population. Pharmacy-related risk factors include age-related physiological changes. As we age, the renal and hepatic function tends to decline, therefore, which may lead to accumulation or maybe drug toxicity in some cases of the medications. Multiple disease states, polypharmacy, compliance is an issue. Social beliefs, what's meant by that? Sometimes patients fear addiction of narcotic medications, so they will refuse to take the medication for fear of addiction, and they may be in extreme pain, but they'll refuse to take it as scheduled or as directed. Functional and cognitive function, as always with any medication, you want to not limit the patient's ADLs, activities of daily living. So and some medications do have the ability to do that, and especially in this population, which tend to be a little bit more sensitive to the reactions of the medications. And cost is another risk factor. Considering that they are on, this population usually are on a limited income, cost is always an issue when it comes to their medications. Pharmacokinetics, the general definition is that it's the time course by which the body absorbs, distributes, metabolizes, and excretes the medication. Kinetics and aging, the first one we'll go through step by step there is the absorption phase. Generally, age does not affect drug absorption, but what does affect the absorption of the medication is how the medication is taken, what it's taken with, and the patient's comorbidities. How the medication is taken, for example, if you have a patient that's getting integral tube feedings, that does have a significant drug absorption interaction with drugs like your Dilantin, and so the nurses or the nurse that's administrating the medication, they will often clamp the tube 2 hours before and 2 hours after the administration of the Dilantin. What the medication is taken with, basically this is just drug-drug interaction. You have an antibiotic, and for example, and you may give it with the, let's say a quinolone, which is your levofloxacin, which is an example of a quinolone, and there's a significant drug interaction between the quinolones and your calcium supplements or your iron supplements. So to increase the absorption of the medication, when the patient is taking a supplement, you want to separate the times by at least 2 hours in that case. Patients' comorbidities may include maybe the patient has some type of bowel or some kind of inflammatory condition going, and that will interfere with the drug absorption. I don't know if I mentioned this at first, but drugs are typically absorbed through the gut. So all of these different processes, the patient's comorbidities, that's where you would be concerned if they had some kind of GI process or disease going on which may interfere with the drug absorption. Drug distribution. As we age, we tend to have a decrease in total body water, an increase in total body fat, decrease in lean body mass. All of these different things typically happen to an aging patient, and it also does have an effect on drugs. For example, the decrease in total body water has an effect on drugs that are highly water soluble, such as ethanol, lithium. These medications tend to have a lower volume of distribution and due to the decreased lean body mass and water. Medications that may be affected, also there's a decrease in lean body mass, and in this population you have an increase in fat mass. Medications that are highly fat soluble, such as your Valium or diazepam, you will have more of that drug hanging around in the tissues for a longer period of time, therefore getting more drug action, more leading to possibly toxicity or accumulation of the medication. Valium, for example, is one of those medications that already has a long half-life. So in an elderly patient, this kinetic property here is very important, because like I said, as the patients age, as we age, we tend to have more fat stores. So if you give them a fat-soluble drug, a highly fat-soluble drug, such as the Valium, which already has a long half-life, and then you give it to an aging individual, it's going to hang around a little bit longer. And in this case, this particular medication will hang around about 90 hours. Drug distribution continued, changes in protein binding. As the patients age due to chronic disease or just general malnutrition, there tends to be a decrease in the albumin level, and this does interfere with drugs that are highly plasma protein bound, such as your Dilantin. So what happens is that you have a patient that's getting a highly plasma protein bound, such as Dilantin, and they have a decrease in albumin. That means that there is less of the drug being bound to that plasma protein, and once the drug becomes bound to the protein, it becomes inactive. So if you have less albumin, less drug being bound, less drug being inactive, more drug being active, more chances of toxicities, more risk factors for the patient. Decrease in drug metabolism and clearance. Like I stated before, as the patients age, they tend to have a decline in their renal function, a decline in the hepatic function, and through the liver, most drugs are metabolized. So with the decrease in the amount of drug even being presented to the liver, you have a decrease in what is being metabolized at any given time. Therefore, you might have an increase in drug action. Same thing with the renal function. You have a decline in the renal blood flow, a decrease in their kidney size. Therefore, you may have a decrease, or you will have a decrease in the amount of drug that's being excreted at any rate of time. Creatinine clearance is one way that we estimate the patient's renal function. And in this particular age group, you want to take into account the patient's age as well as their weight. As you age, your numbers go up, your weight typically goes down. Serum creatinine may look normal, but when you use this formula by Cockcroft and Galt and calculate the estimated calculated creatinine clearance for an elderly patient, it's typically going to be low because you take into account the increase in age, decline in weight, and so that's a very significant point when dosing medications that are renally toxic. We may have to extend the intervals or maybe decrease the amount of drug that we're giving. Polypharmacy has several definitions. It could be greater than 5 medications, more than 12 doses a day, more than 1 medication per indication, or medication use without an indication at all. Generally, it increases the chances of drug-drug interactions, adverse drug reactions, and cost to the patient. and also decreases compliance. The take-home message here is that studies show that as you increase the number of medications, you increase the chances of drug-drug interactions and harm to the patient. Clinical significance of drug reactions. They cause about 10 to 20% of hospitalizations in patients greater than 65. They do complicate the hospital admissions by up to 15% in patients greater than 70. They will prolong the length of stay in a patient by 2 days and can be fatal. Just keep in mind, as I stated before, geriatric patients do tend to be a little bit more sensitive to medications and their reactions. So, you know, if we have any type of drug-drug interaction or adverse event, it can be, it is very serious and can be fatal. How do we get to polypharmacy? Physicians do contribute, patients do contribute to polypharmacy. How do physicians contribute to polypharmacy? Treating an ADR with another medication. For example, you have a patient, you start them on a new medication, and all of a sudden they start to cough. So then we tell them, okay, just go to the pharmacy and get some Robitussin. That's just, you know, treating an adverse reaction with another medication. Therefore, you're adding something else, you lengthening the medication list, and could potentially cause a problem. Also, failure to get a complete medication history. Oftentimes, patients don't look at over-the-counter medications or things that they get at Walmart or Walgreens. They don't look at those things as medications, so they will fail to reveal that. When you ask them about their medications, they will only tell you what's being prescribed, and they'll leave off all the extra Tylenols, all the extra Advils, and so on and so forth. And also, they will definitely leave off all the herbals and vitamins, which do cause a lot of drug-drug interactions. And we really need all of that information so that we can assess them their health conditions for to see what's going on with the patient. Also, inadequate attention to the patient's physiological changes. If you weren't familiar with the fact that the elderly patient, as they age, they tend to have more fat, less water going throughout the body, then you won't be able to apply the fact that the medications may react differently, or the patient may respond differently to different medications. For example, the Valium. We may give a very small dose of Valium to an elderly patient, but just that knowing that the physiological changes that occur, more fatty tissue, highly fat-soluble drug, therefore it's it may be a small dose, but it'll hang around a long time, and you'll get all those toxic effects. Patients contribute to polypharmacy. How do they do that? They'll go to the doctor's office and they will want a pill for everything that's wrong with them. They're coughing today, they want a medication. You know, there's a little soreness. They want something for every complaint that they have, and patients can be very demanding. Multiple physicians. Patients do see different doctors. It's very nice when they see different doctors in the same system, so we could just pull up the information on the computer, but when they see different physicians at different facilities or different companies or private practice, those doctors depend on the patient telling them that information, and oftentimes that's not communicated. So we may have one doctor prescribing Vicodin at one location. We may have another doctor prescribing Darvocet, and the doctors don't know that what's going on, and the patient may get overdosed on the Tylenol component of both of those medications. Multiple pharmacies work the same way. It's okay to use different pharmacies, but the ideal situation is to use the same pharmacy chain. That way, any pharmacist, when they pull up your profile, your whole med list comes up, and then they can make those adjustments or judges upon, based on what they see. But when you have a patient that visits on any given day, they go to Target, they go to Walmart, Walgreens, wherever it's convenient, Kroger's, wherever they are that day, those different systems do not interlink, and the pharmacists don't have any idea what's going on other than what the patient tells you. And they've made pharmacy so convenient now where you can just drive up, drop it off, and you don't get too many questions asked. I just had a prescription filled myself last night, and I experienced that. They didn't ask me anything, no allergies or anything, and I'd never been there before. But those types of things do happen, and you know, to our patients. Multiple diseases. As you age, you tend to have more medical problems. Not much we can do about that, but self-medication also contributes to polypharmacy. And what has happened over the last couple of years or so, a lot of medications have been that were by prescription are now available over the counter. So we have, everybody in this room has the ability to go to your local pharmacy and get medications such as Pepcid, which just a couple of years ago was by prescription only, or Claritin, just 2 years ago was by prescription only. So we can go and we can get those different medications and we can treat ourselves, or at least think we are. Here's an example of a prescribing cascade where the patient came in and got captopril, developed a rash from the captopril, was told to use Benadryl, and it was an elderly patient, and the adverse event was a delirium and constipation. Stepwise approach to intervention of polypharmacy. First and foremost, disclose all medications being used. Identify medications by generic and drug class. For prescribers, it's lots of drugs out there, and what I tell prescribers is that kind of be familiar with the different effects of different drug class. For example, if you have a medication and such as Benadryl, and if you just familiarize yourself with the fact that it's anticholinergic in nature, then you will know that all those different anticholinergic side effects, dry mouth, delirium, constipation, all those things will come under that drug class. Identifying the clinical indication for each medication. Know the side effect profile of each medication. Like I said, it's a lot of medications out there. You might not know every single side effect, but if you classify them by drug classes, you can. It would be easier. Identify risk factors for an ADR in an elderly patient. You know, we've talked about their risk factors, so if you familiarize yourself with the risk factors, then we can maybe try to intervene with polypharmacy. Eliminate medications with no benefit. Eliminate medication with no clinical indication. Let's go back to the first one. Eliminate medications with no benefit. Maybe you have a patient that comes in and they have all of these different vitamins, in addition to all the different prescription medications, in addition to the over-the-counter things. So maybe we can look at the list or the medications and try to eliminate things as we see fit, because remember, this is also the population that is on a limited income, and they will share information among themselves and buy all different vitamins and things that they may not need. Substitute a better medication. There are cases where we do use prescription medications in the elderly, in this population, and we do get positive side effects. For example, let's say we have a depressed elderly, not eating, not sleeping patient. So rather than giving that patient 3 medications, one for the depression, one for the appetite, and one for the sleep, maybe we can give them a medication such as Remeron, which we treat the depression, and we do get the positive side effects in this population, which is to stimulate the appetite and to induce sleep. Also, use a single drug with infrequent dosing schedule, and this is just simple. If we can switch some things over to from PRN to schedule, like some of our pain medications, instead of giving the IR formulation, which is immediate release, maybe we can give them the longer acting and just do a BID dosing versus a Q4-hour type regimen. This chart just shows the rate of adverse drug reactions by number of drugs, and it just shows how the more medications that you have on board, the more chances of having an adverse drug reaction. The World Health Organization definition of an adverse drug reaction is listed. Any noxious, unintended, and desired effect of a drug which occurs at doses used in humans for prophylaxis, diagnosis, or therapy. Adverse drug reaction has three different categories: drug disease, which is an exacerbation of the disease by a drug; drug-drug interactions, which is altered pharmacokinetics of one drug when taken with another; drug food can reduce or increase drug absorption, reduce first-pass metabolism, or delay gastric emptying. Here's a chart that shows some common disease states in an elderly patient and the different medications that may worsen that disease states. For example, the BPH, if you give them an anticholinergic type drug, such as your Benadryl, your amitriptyline, maybe will worsen the urinary retention. A demented patient, giving them an anticholinergic type drug, or a benzodiazepine, which would be your Valiums and your longer acting benzos, such as your Valium. We do give them benzodiazepines, but we typically give them the shorter acting ones, such as your Ativan. In this case, with the demented patient with the anticholinergic drug, we have a chance of increasing their confusion or delirium. Diabetes, giving them a prednisone or something, we can take a chance at increasing the sugar, the glucose levels. Orthostatic hypotension, diuretics, TCAs, or your tricyclic antidepressants, which is your amitriptyline, nortriptyline, vasodilators. They will may worsen dizziness, lead to falls, syncope, hip fractures, hospital stay, so on and so forth. PUD, patients receiving NSAIDs, which are your indomethacin, ibuprofen. Anticoagulants would be like your warfarin. You may have a chance of the patient having a GI bleed or worsening of the GI bleed. And renal impairment, NSAIDs, again, antibiotics, may lead the patient, if not dosed appropriately, to acute renal failure. Adverse drug reactions in elderly patients are 7 times more common in patients between the ages of 70 and 79 versus patients between the ages of 20 and 29. Patients 65 and older are at an increased risk for an ADR because they tend to be a little bit more sensitive to medications. The ADRs in these populations are a lot more severe. 30% of hospitalizations in patients 65 and older result from an ADR, according to the Beers article, 2003, and ADRs occur in about 2 to 44% of hospitalized geriatric patients. Adverse drug reactions in elderly patients, possible signs and symptoms of an adverse drug reaction: confusion, falls, urinary retention, excessive sedation, decreased PO intake, constipation, and just a general failure to thrive. What happens when this elderly patient presents to the doctor's office? Lots of times they just present this way, confused, constipated, sleeping, and what will happen is if the doctor isn't paying a lot of attention, or the provider isn't really paying attention to this this elderly patient and how they age, they will overlook the fact that any one of these signs and symptoms could be related to a drug. There are tons of drugs out there that can make the patient confused, can lead to the patient falling, worsening of the urinary retention. So the take-home message with this slide is that always look at the signs and symptoms, and always look at the medications to see if they could be related to any of these signs and symptoms that the patient is presenting with. Noncompliance. 40% of patients just do not take medicines as prescribed. And most patients take less than what is being prescribed. This does not just apply to elderly patients, but today's topic is on geriatric patients. This applies to the population. 40%, that's quite a bit. People just do not take medications as prescribed. What happens is we get an infection, we start the antibiotic. 2 or 3 days later, we start to feel better. We stop it. I don't need it anymore. Or maybe we have the patient that has a TI 3 times a day antibiotic, and they just can't remember to take that middle dose. But it's not just pinpointed to the elderly population. Noncompliance is an issue all the way around. And most patients do take less drug than what's prescribed, whether they cut out a dose during the day or they stop it when they start to feel better. But I try to encourage patients to take the medication as prescribed. When you start an antibiotic, you will probably start to feel better after 2 to 3 days, but that doesn't mean that we have gotten rid of the bug, and we do need to complete the medication, because that's how we get into trouble with antibiotics and lead to resistance of antibiotics where they're not working anymore treating that particular bug, because we've taken so much drug and then we stop, and then it won't work again when we try to use it, and the next time the infection makes the patient so sick where they have to go into the doctor. So we have to try more medication, more expensive medication, and so on and so forth. Causes of noncompliance in an elderly patient could be forgetfulness, just misunderstanding of the verbal direction. So I try to encourage the prescribers to write and verbalize what the directions are. Try to talk to a caregiver as well for an elderly patient. Inability to purchase the medication. If they don't have the money, they can't get the medication, so they're not going to take it. Trouble with side effects. This one is on the list for elderly, but it applies for all the general population. If there's a problem if you having a bad taste in your mouth every time you take that medicine, you're not going to take it anymore. But what we try to do is to encourage counseling that this is a potential side effect that might happen, so that patients will at least try to endure the 7 days of the medication to get the full effect. Difficulty swallowing larger capsules or tablets. So this one applies definitely to the elderly population. And what they've done, some of the manufacturing companies, they've come up with different formulations to help this population. One medication in particular comes in a wafer, and if they can eat it kind of like a cracker. They have another one where it just dissolves on the tongue. One of the antipsychotics. So the manufacturers are trying to respond to some of the needs of the elderly patients. For your elderly patient that's living out in the community, maybe they're just having a problem opening up those tops on the medication containers. And when I talk to the community, I do encourage them that if they are having that problem, they can always ask the pharmacist to switch out those tops and give them the easy to open pop-up tops. The only thing is that we want to try to make sure there's no children in the house, because that's the reason why the safety caps came about. Strategies for enhancing compliance include providing social and nursing support. When patients are admitted to the ACE unit, and we have determined that compliance is an issue, what we'll do on discharge is try to get home health involved, and maybe we'll have the home health nurse go out for a couple of weeks and train, teach, show the patient how to take the medication appropriately. Maybe the nurse will set up a pill box for the patient. Maybe the nurse will teach the family the most appropriate way to take the medication, trying to help them with their compliance. Being aware of the patient's risk factors. If you have a demented patient, maybe, if the cognition isn't where it needs to be, then maybe that's going to be a problem with why they're not taking their medication. Also, depression, decline in function, and living alone has contributed to noncompliance. If they live alone, nobody knows really what's going on but what they tell you. Careful attention to the patient's education. Sometimes we have to make sure that we explain things in a way that they understand. We're dealing with the elderly population, and maybe they have not finished high school education, and so we have to talk in a way where they can understand what's going on. Discourage pill sharing. I get this one all the time, where you have a spouse and husband and wife team, and one blood pressure pill is working for one, and the other one doesn't understand why they can't have the one that the wife has. It goes back and forth. But what I try to explain to them is that particular high blood pressure medication that you're taking has been prescribed for your needs, and your spouse may not have the same needs as you, or vice versa. So don't share the pills. Do consult your physician and let them determine what's the best medication for you. Last but not least, pill boxes and written charts do help with compliance. The pill boxes are very convenient. You can stick them in your pocket, your purse. They're coming. They're very small. Some are very small. Some are very large. But for the on-the-go senior, pill boxes tend to work really well for them. Written charts, just a little reminder. They can stick them on the refrigerator or somewhere where they frequent in the household, and just as a little reminder, it's 8 o'clock. 8 a.m. or however they take their medication, this is what time I need to take this medication, or sometimes they set it up where they put breakfast, lunch, dinner, and then they know that's when the times they need to take the medication. Error reduction efforts. Most drug-related problems in elderly don't involve medications that are on anybody's bad drug list. And that's where we get the Beers criteria, where basically the Beers criteria is information that's meant to apply to the general population of elderly patients. It makes two different statements. Medications are categories to avoid in this population, and medications to avoid in certain medical conditions. The first criteria came out in 1991. It's been updated twice since then. The last update is 2003. And it's not to criticize any medications that's out there, but it's just collectively some different drugs and that are out there that have been potentially inappropriate in an elderly patient. And we'll briefly go over some of the drugs that appeared on the Beers list. Under your sedatives and hypnotics, we've talked quite a bit on diazepam, Valium, so we kind of already know why that drug would appear on the Beers list. The antidepressants, amitriptyline and doxepin, those two medications very highly anticholinergic, so the patient will get the confusion, the falls, the sedation, the constipation, all those symptoms that I listed before. Same thing with the muscle relaxants that appeared on the Beers list. Actually, these are the muscle relaxants that are out there and available, and they all are very highly anticholinergic. So there we go again, the confused, delirious, constipated, falling elder patient. Antipsychotics, Haldol appeared on the list because it does have some anticholinergic side effects, and you do have the risk of extrapyramidal actions. Digoxin, which is a great drug, but it appeared on the Beers list simply because as we age, we tend to have a decline in renal function, and that drug is highly renal toxic. The hypertensive, methodopa, reserpine, those two medications tend to exacerbate depression. So one of the geriatric syndromes is depression. So we don't want to give them any kind of medication that may worsen whatever disease states or medical conditions that they may already have. Hydrochlorothiazide in doses greater than 50 milligrams a day appeared on the list. Lots of that have to do with renal function also. If the creatinine clearance isn't greater than 30, then you won't get any results from the drug. Antihistamines, tons of antihistamines, but Benadryl appeared on the Beers list because of the highly anticholinergic type side effects. Your analgesics, meperidine and propoxyphene, lots of CNS side effects, acute delirium in an elderly patient, so you want to use these medications with caution. Demerol, meperidine is highly fat soluble, so that's another one that'll kind of hang around for a while. Propoxyphene, lots of CNS side effects, and it's the one of the components in Darvocet. So, according to the Beers list, the propoxyphene component of Darvocet doesn't have any more analgesic effect than just using Tylenol alone. So, but you do get all the side effects of using this opioid, constipation, confusion, so on and so forth. NSAIDs, indomethacin, appeared on the Beers list because it has lots of CNS side effects as well. Your antiemetics, the Tigan and the promethazine, does have some anticholinergic type side effects, so you want to use those drugs with caution. Any of these drugs, if they are used in an elderly patient, ideally you want to start low and go slow. So if you did have to use a Benadryl in this population, because we do have instances where we have no other choice but to use Benadryl, but as a matter of fact, it's part of some of our protocols here at the hospital. Blood transfusions, we give Benadryl. That's part of the protocol. But in this population, we would want to reduce that dose to the lowest dose possible. And what we do here is 12.5. So you do start low, go slow, but you do you can go up on the drug if the patient tolerates it. Antispasmodics, highly anticholinergic in nature. Your oral hypoglycemics, chlorpropamide. This drug is a very old medication used for diabetes. I don't know too many people that are prescribing it anymore, but it appeared on the Beers list because it's very, very long acting, has a very long half-life, and it can put the patient in hypoglycemia. So you want to, if this medication is being used, want to use it with caution in an elderly patient. Supplements, iron appeared on the list because doses greater than once a day. According to the list, Beers list, it doesn't have, you don't get any more being absorbed, but you do get all of the side effects of the GI upset, the constipation. Oh, okay. Do I have any questions? That's the end of my presentation. Are there any questions?
I do. On iron, is it better to use the ferrous sulfate or the ferrous gluconate?
Ferrous sulfate, you get more elemental iron, so you get more of the ferrous gluconate. You don't get as much of elemental iron in a period.
Okay. Well, once a day dosing is better.
Yeah, according to the Beers list. But you'll still find TID, BID dosing.
Under the heading, I guess, of non-compliance, we did a survey about 10 years ago of seniors in Galveston County that were 75 and over. It was called the Health of the Public Needs Assessment. We did this thing on there called a typical day, and we would ask the senior subjects what they did the very first thing they get up in the morning, and then what did they do next, and then what did they do next until the end of the day, and they go to sleep, and if they also would get up at night. Well, about 75 to 80% said that the very first thing they do when they get up is take their medication. You know, and I was wondering, is that something, I'm not in clinics, I mean, are they looking for strategies to get people on a routine to take their medication at specific times of the day that would be easier for them to remember?
Okay. Two sides to that story. When I talk to patients, while they're in-house, they do have a time. They have an 8, 12, and 16, 20, 100 type time. But you have your elderly patient that can't often keep up with all those different times, or maybe the caregiver, both are older and they have other things going on throughout the day. So it's kind of, for me, it's difficult to tell them to take your medication at certain times. So what I tend to do is to tell them to take it with a routine. With breakfast, or when you get up, or with your lunch, because their time that they get up in the morning and have breakfast may be 6:30, and what happens is the provider or whoever, the pharmacist, will say take this at 8 a.m. and they're trying to struggle to get those times. At home here, we can coordinate that. They have no choice. The nurse is going to bring it to them. But at home, it's kind of difficult to have a schedule that doesn't fit your schedule. You know, and you have an elderly patient that maybe they get up at 5 a.m. and have their breakfast and coffee or whatever, and that's what I tend to tell them to do. Do the schedule that's most comfortable and convenient for you, but this is when this medication should be taken. Okay.